And I hope everybody's encephalopathy is better now. So we'll start off with the case straight away. We have a 45-year-old male who was shifted to ICU from ward with complaints of altered sensorium since 1 day, which has now increased, urine output which is low since morning. Ascitic tapping was done in the morning, after which his urine output is slightly better. Oxygen saturation is 84% on room air, a classical CLD case we face every day in our ICU. On eliciting history, he is a chronic alcoholic, so ASH-related CLD. Has been diagnosed as a chronic liver disease 1 year back and has not been abstinent. So how do we proceed? First, what we are dealing with. So we have a patient who has a decompensated liver disease with decompensation manifesting in the form of ascites, encephalopathy, and there was some decrease in urine output, so probably hepatorenal syndrome. So we'll take one of the complications as we go. What is hepatic encephalopathy? Hepatic encephalopathy is a syndrome of neuropsychiatric dysfunction caused by portosystemic venous shunting with or without intrinsic liver disease. This is important. So it is a progressive failure of neurotransmission. Now there are different types of hepatic encephalopathy as per the disease. They are classified as type A, which is associated with acute liver disease, type B, which is associated with portosystemic bypass, no intrinsic hepatocellular disease associated with it. Type C is the one which we'll discuss, which is associated with cirrhosis, and type D, which is associated with the disorders of urea cycle. So what is pathogenesis? So pathogenesis is mainly focused around ammonia generation and ammonia, which acts by different pathways and how the hepatic encephalopathy occurs. So first is that in the astrocytes in the brain, it causes glutamine formation from glutamine, and this glutamine, it also inhibits the release of these glutamine in astrocytes, so that causes astrocyte swelling. It also being a neutral molecule, it is very easy for the ammonia molecules to cross the blood-brain barrier. Thirdly, it alters with the generation energy metabolism by inhibiting the citric acid cycle, where the alpha-ketoglutarate, which is substrate for the citric acid cycle, goes into glutamine formation. Also increases the GABAergic neurotransmission, which is a neuroinhibitor. Increases cerebral tryptophans, especially increasing the serotonin formation, which is again a neuroinhibitor. And also causes inhibition of the chloride channel, which causes the inhibition of the transmission in the CNS. So there's one molecule ammonia which acts by multiple pathways. So what are the precipitating causes? We all know dehydration, constipation, GI bleed, infection, increased dietary protein. I like to stress hypokalemia. It is one of the most important and most often ignored thing in our ICU. If you are not correcting hypokalemia of your hepatic encephalopathy patient, it will not get better. Because in hypokalemia, there is increased renal tubular ammonia formation, which is both excreted into the renal tubule and as well as the peritubular capillaries. So this, along with that, when there is hypokalemia, you have metabolic alkalosis in the patient. So this metabolic alkalosis increases the formation of ammonia from ammonium. And thus, ammonia again, as I already told, is a neutral molecule. It crosses the blood-brain barrier easily. So always correct your potassium if you want to correct your hepatic encephalopathy. Hyponatremia, renal failure, urinary tract obstruction, sedative drugs which are acting on the CNS. TIPS, I know everybody knows what TIPS is. And hepatocellular carcinoma. Why does TIPS cause HE? Anybody? It's a very simple question, but yeah, exactly. So most of these factors have a common underlying mechanism. It increases the load of ammonia either by increased substrate production, increased metabolism, or decreased excretion. Grades of encephalopathy given by Westhaven. Grade 0, no abnormalities detected. Grade 1, this is shortened attention span. You can ask your patient to do the addition and subtraction. You'll not be able to do it. Grade 2, this is where you see the asterisks and the lethargy, apathy, disorientation to time. Type 3, your patient is somnolent, semi-stuporous, and type 4 is where most likely you'll like to intubate your patient. He's in comatose state. So what are the diagnostic steps? Most important is the history of the patient. History and clinical examination are most important, but you definitely, the flapping tremor asterisks we already do, you definitely need to do a CT scan. MRI, most often we don't do, but CT is the most feasible thing which you can do, and you should definitely do because these patients are obviously prone to bleeding. So a structural complication of bleed should always be ruled out. Blood ammonia levels, you should do arterial level, venous levels have a lot of fluctuations. So if available, Arterial sample should be done. In our unit, we generally do an arterial sample only if we have an arterial line, because already coagulopathic, we don't try to prick the arteries with these patients. So the level is more than 150. This corresponds to high hepatic encephalopathy. And if you are sending your patient's blood sample for ammonia, try to send it on an ice pack and try to get it done within 20-30 minutes, because after that there is auto degeneration within the blood. So your levels will not be accurate. Now, how to treat hepatic encephalopathy? You have to correct the precipitating cause, correct the dehydration of the patient, stop diuretics. Most often these patients are on diuretics in the OPD therapy. Give intravenous fluids. Bleed is one of the most common causes. You correct the bleed by coagulopathic correction or do an endoscopy if there is a varicose bleed or others. Correction of infection, another one of the important points. Now come to the pharmacotherapy, which is specific to hepatic encephalopathy. So you give lactulose. It is a non-absorbable disaccharide administered orally in doses of 30 ml every 2 to 4 hours. And you need to see that your patient passes 3 to 5 semi-formed stools. If that's not the thing, you need to give more of lactulose. Orally in grade 1 and 2, but you'll need to put an RT if you have a higher grade. Rectal enemias should be given if your patient has ileus tensitis, and if you have an inability to insert NG, but make sure you have ruled out the hemorrhoids, because most often you go and give rectal anemia and after some time the sister comes running, the patient is having a PR bleed. Right. So retention enemias can also be given by mixing 300 ml of lactulose with 700 ml of tap water. And one of the common side effects of lactulose is that it causes a lot of bloating sensation. There is abdominal distension, a sweet taste is left, and there can be a cramping of the in the bowel. So mechanism of action in colon, lactulose is catabolized by bacterial flora to short chain fatty acid, which lowers the colonic pH to about 5. With reduction in pH, this favors the formation of non-absorbable ammonium from the ammonia, and thus this ammonium is trapped in the colon and reduces the plasma ammonia level. A lot of these patients are on oral antibiotics which are non-absorbable, like rifaximin, and dose is 550 milligrams BD, but these are more of OPD medications. If your patient is in ICU, is already receiving a broad spectrum antibiotic, you need not give it, but your gastroenterologist may or may not agree with you. Ours do agree with us. We don't give rifaximin if our patient is on a broad spectrum antibiotic. Next is L-ornithine L-aspartate, LOLA, or hepamers. So ammonia is removed from the body by formation of urea in the periportal hepatocytes and or by synthesis of glutamine from glutamate. In patients with cirrhosis, the activities of carbamyl phosphatase synthase and of glutamine synthetase are impaired, resulting in hyperammonemia. What is this? This is basically ornithine donor. So this ornithine serves both as the activator of carbamyl phosphatase synthase and ornithine carbamyl transferase in periportal hepatocytes, and thus as a substrate for ureagenesis. But you should be careful when you are giving this. If patient is in renal dysfunction, especially if the creatinine cutoff, generally what we take is 1.5. It is above 1.5. Don't give hepamers. Dietary restriction of protein is no longer recommended. You should give as 0.8 to 1.5 grams per day. Supplement zinc because it is cofactor in most of the enzymes. Keto analogs of branch chain amino acid can be given as they have been used to decrease the ammonia levels by amination of the corresponding amino acid, inhibiting thus the protein breakdown. And other experimental therapies like sodium benzoate, which is ammonia scavenger and helps in excretion of ammonia as uric acid. But generally, these are not used in day-to-day clinical practice, naloxone and flumazenil. So, coming to the next topic, after hepatic encephalopathy, what are the causes of renal failure in your liver disease? So, it is one of the most common. They can have AKI because of the sepsis. Again, hypovolemia, they are already on diuretics, dehydration. They can have GI bleed, right? They can be on multiple nephrotoxic drugs, may have received multiple CTs, triphasic CTs, all those things. So contrast agents, and obviously what we want to discuss here, hepatorenal syndrome, which is one of the most advanced stages of the physiological alteration. Now creatine can be falsely low in these patients, which is actually not mentioned here, but because of two things. One is that because of the poor muscle mass, Another thing is high bilirubin level interfere with your creatinine calculation in the labs. You can go and ask your biochemistry friends, they'll verify this. So if your bilirubin is high, your creatinine levels are not accurate. So even small changes in the creatinine in these patients, you should be very vigilant. Now if you go for a urine analysis, HRS more or less resembles the prerenal hypovolemia, where the osmolality of urine is 500 and urine sodium is less than 200. So hepatorenal syndrome is defined as a functional renal failure in patients with liver disease with portal hypertension. It constitutes the climax of systemic circulatory changes associated with portal hypertension. And this syndrome occurs exclusively in patients with ascites. So if your patient does not have ascites, it is not HRS, but it can be AK or any other thing. So what is the pathophysiology? In patients who are cirrhotic, there is increased nitric oxide production, and because of the portal hypertension, there is splanchnic vasodilation, which decreases the effective circulating volume. Now what this causes, it increases the RAS1 stimulation, it stimulates the brain, causing vasopressin release, and also your baroreceptors, increasing the sympathetic response. So what is this? It causes the vasoconstriction of the renal vessels. Thus, there is increase in renal sodium retention, decreased capacity to excrete free water, causing hyponatremia and decrease in GFR. So if you have a patient who is suspected to be in HRS, red flag signs are dilutional hyponatremia, increased cardiac output, and a decreased MAP of less than 80. Renal perfusion is actually auto-regulated well in the range of 70 to 75 mm of Hg. Once the blood pressure goes down, it is actually absolutely proportional to your perfusion pressure. So the auto-regulation is lost. So if your MAP is below 80, the renal insult is more likely. So what are the precipitating causes of HRS? Bacterial infection, large volume paracentesis, one of the most common iatrogenic complications that we do, GI bleed, and alcoholic hepatitis. Now the classification of HRS was type 1 and type 2, which has now changed to HRS AKI and HRS non-AKI. Non-AKI is further classified as HRS acute kidney disease and HRS chronic kidney disease. So what do we have? You are able to read? I don't think so. Now better? Right. So for HRS AKI, it is actually now based on the KDIGO guidelines. So if there should be an increase in serum creatinine of more than equal to 0.3 milligrams per deciliter within 48 hours, or there should be an increase in serum creatinine of more than 1.5 times from the baseline. And the creatinine value within previous 3 months should be taken when available and may be used as the baseline. And you should take the value which is closest to the presentation. Apart from that, the rest of the things remain the same, that there is no response to diuretic withdrawal and 2 days of fluid challenge with 1 gram per kg per day of albumin of 20 or 25%. There is cirrhosis with ascites, there is absence of shock, and there is no current or recent use of nephrotoxic drugs or no signs of structural kidney disease. For HRS non-AKI, we have 2 forms. HRS acute kidney disease, it is estimated basis on the glomerular filtration fraction, it should be less than equal to 30 ml per kg per 1.73 meter square for less than 3 months. And for CKD, it is more than 3 months, right? Next is biomarkers. For NGAL is the most studied biomarker in cirrhosis and has shown the greatest diagnostic accuracy in differentiating ATN from AKI-HRS. And compared to the plasma form, urine NGAL is superior. And cutoff which is taken generally is 220, although some studies have quoted 140 also, but 220 is generally taken as a cutoff for the creatinine. NGAL. Now coming to the management of HRS. You should remove the causative factor, you should, elimination of the nephrotoxic drug, treatment of the bacterial infection, bleeding, again, NSAIDs, diuretics, supplement intravascular volume. But let's come to the specifics of the management. This is the guideline which was given by European Association of Study of Liver in 2018. You're able to read, right? So, first and foremost, vasoconstrictor and albumin are recommended for all patients that meet the current definition of AKI-HRS. Terlipressin plus albumin should be considered as the first-line treatment option for the treatment for AKI-HRS, and they should be preferably used in infusion form that decreases the overall dose requirement. And what you should do in case of no response to your terlipressin, that is serum decrease in the serum creatinine of less than 25% from the peak value after 2 days. The dose of terlipressin should be increased in a stepwise manner to maximum of 12 mg. And trust me, I have never, or nobody in my unit has used 12 mg of terlipressin. What maximum, I think what we have used is 4 or 5 mg, but never 12. Albumin solution of 20% should be used in the dose of 20 to 40 grams per day. And noradrenaline can be used as an alternative to terlipressin, but the information or the evidence is limited, so it is a weak recommendation, others are strong. In contrast to terlipressin, use of noradrenaline always requires a central line, and in several countries transfer to ICU like in our setup. So although there is a major difference between the cost of noradrenaline and terlipressin, but what the guideline says that since you have to give norad by central line, ultimately the cost comes out to be the same. And according to the new definition of AKI-HRS, complete response to treatment should be defined by final serum creatinine within 0.3 milligrams per deciliter from the baseline. And if it is more than equal to 0.3, it is a partial response. So we all know that terlipressin, norad include a lot of ischemic and cardiovascular side effects. So select your patients carefully, especially the patients who have history of cardiac events. Patient once on terlipressin, you should be very vigilant about the plethysmograph. If the pleth is not coming, the waves are not nice, you should be suspecting terlipressin overdose. In case of recurrence of AKI-HRS on cessation of treatment, a repeat course of therapy can be done, and terlipressin or albumin is effective in treatment of HRS outside the criteria of AKI also, formerly known for AKI-HRS2, right? And there is insufficient data for tips to be allowed in AKI-HRS, but you can do it for the non-AKI part. And liver transplant is the best therapeutic option for these patients. Decision to initiate RRT is based on the severity. Dual transplant, they are still, it remains controversial. They are still not recommending it. And albumin at 1.5 gram per kg dose on day 1 and 2 and 1 gram per kg on day 3 should be given in patients who have SBP. We'll come to it later again. Norflox 400 milligrams per day should be given as a prophylaxis for SBP to prevent HRS AKI. Now next is something wrong here. Something has gone wrong with this. Now we move to ascites. Ascites, most of the times we are doing a diagnostic abdominal paracentesis or a large volume paracentesis also. Preferable site is a lower quadrant. Always use ultrasound to do ascitic tapping. Otherwise, most of the time the vessel injury is there. If you are doing blind and patient lands up with hemorrhagic complications. So routine use of FFP and platelets are not recommended. We routinely do not give any FFP or platelet to our patients. Even at INR of 3, we do without any blood products, we just use ultrasound. Once you are doing ascites, test for cell counts, differential, do a SAG, and if you are suspecting an infection, culture at the bedside itself. So serum ascites albumin gradient more than 1.1, portal hypertension, heart failure, Budd-Chiari syndrome less than 1.1, transudative things, infection, pancreatic cancer, tuberculosis. Right, for treatment of ascites, you should abstain from alcohol, restrict sodium to 2 grams per day, There should be no fluid restriction until unless your hypervolumic hyponatremia is less than 125 millimoles per liter. Use dual diuretics, spironolactone and furosemide in the dose of 100 to 40 milligrams. And you can also use Vaptans as they mobilize the ascites, increasing the urine output. Avoid ACE inhibitors, ARBs, NSAIDs, beta blockers. And in diuretic resistant ascites, you can do furosemide test. What is furosemide test in this setup? I am not talking about the AKI furosemide test. Anyone? Slightly loudly. I can't hear you, but 300 does not figure in the answer anywhere. So what you do is you give 80 milligrams of furosemide and you measure the urinary sodium over 8 hours. So if it is less than 80, you have a diuretic resistant ascites. So it is not the furosemide challenge which we do for AKI. This is different. Tense ascites, large volume paracetamosis is required. As per the American Society, you have to give 6 to 8 grams of albumin per liter of ascites if the volume of tap is more than 5 liters, and will be successful only if there is sodium restriction which is adhered to and MAP is maintained. Now coming to the refractory ascites. Refractory ascites is which is unresponsive to sodium restriction along with high dose of diuretics, that is 400 of spironolactone, 160 of furosemide, along with inadequate secretion of sodium, that is less than 78 or 80 millimoles per day, and associated with development of complications like encephalopathy, sodium of less than 120, potassium of more than 6. Treatment options are you do a therapeutic tapping with albumin, add midodrine 7.5 milligram TDS. Transplant is obviously an option, or you can go for tips for reducing your portal pressures. Next is what is SBP. So it is diagnosed if there are more than 250 polymorph cells in your ascitic sample without evidence of intra-abdominal surgically treated cause. And it is because both your cellular and humoral immunity is impaired in your cirrhotic patients, and this causes decreased bacterial clearance and a functional alteration in the intestinal mucosa, causing bacterial translocation from the gut to the ascitic fluid. Treatments, once you have diagnosed, intravenous antibiotics should be administered. What they recommend is third generation cephalosporins. But if your patient has been in and out of hospital, has had multiple times, it is better you give carbapenems. Generally these already are resistant in our Indian setup. And you should give albumin, start with 1.5 gram per day, and by day 3 you can give the dose of 1 gram per kg. So once we are over with the ascites, next is what are the causes of hypoxemia in liver patient. Apart from the routine complications which other patients have, 2 causes of hypoxemia in liver patients are and hepatopulmonary and portopulmonary. Portopulmonary I will not be covering because it is more or less a pulmonary hypertension. You treat it like pulmonary hypertension. So we will cover only HPS here. So hepatopulmonary syndrome is characterized by defect in the arterial oxygenation induced by pulmonary vascular dilatation in the setting of liver disease. And the definition of arterial hypoxemia associated with HPS is based on measurement of partial pressure of oxygen that is performed with the patient in a standardized position, preferably sitting and at rest. So, sorry. Where are we? Right. So this is a mechanism of hypoxemia in hepatopulmonary syndrome. What happens is basically there is dilatation of the capillary around your alveoli, and what is important is you should remember this: the size of the capillaries. Normal is 8 to 15 and dilated is more than 15, can be 500. What happens is there is partially oxygenated blood. There is because of the increase of the width, so oxygen is not able to reach the RBCs on the other end. And this size is important because we need to discuss. We'll discuss the diagnostic parameters now. So diagnostic criteria is we have oxidation defect. Partial pressure of oxygen is less than 80, or an alveolar arterial gradient is more than equal to 50. Normal is less than 50. While breathing ambient air, there is pulmonary vascular dilatation. There is positive finding on contrast enhanced echocardiography, or abnormal uptake in the brain of more than 6% with radioactive lung perfusion scan. We'll come to it in just a second. Liver disease, obviously you have portal hypertension with or without cirrhosis, and you can classify the degree of severity as mild, moderate, severe and very severe, where partial pressure is 80, 80 to 60, 60 to 50 and less than 50. So how do you diagnose? What you can do is you can do a contrast enhanced echo. It is basically done using the agitated saline. So you have a three-way, attach two syringes and inject saline continuously in both of them. So the saline becomes agitated, there are a lot of bubble formation, and then you inject it into the patient. So once you have injected it, you do a echo, and within 3 to 5 cycles, 3 to 6 cycles, it will appear on your left side. Once it is appearing on the left side, that means it has crossed the pulmonary bed. Right now, the size of what they say is the size is around 10 to 15 microns, and because the size is 10 to 15 microns, it will only be able to cross once the vessels of the pulmonary bed are dilated. If they are not dilated, it will not cross. Right? What you can also do is a MA scan or mass scan. It is alternative to contrast intense echocardiography. Under normal conditions, 99 technetium labeled albumin microaggregates that exceed the size of 20 microns in diameter are normally trapped in the pulmonary circulation, and we have already discussed because of the size of the vessels. In the presence of the shunt, what they do is they cross the pulmonary bed, and you can detect the presence of these molecules in brain or spleen. So more than 6% uptake in the brain suggests that the pulmonary bed is dilated. So what are the features of HDS? There is dyspnea on exertion, at rest, or both. The typical finding is the orthodeoxia, that is arterial deoxygenation is improving in recumbency. So hypoxia and dyspnea are induced or worsened in an upright position. We all know this. This phenomenon is explained by the worsening of diffusion-perfusion mismatching and an increase in the shunt fraction in the upright position because of increased perfusion to the lower lobes. Clinical features, all the signs of hypoxia and CLT, that clubbing, cider nevi, evidence of liver disease. When you do an X-ray, it can be perfectly normal and still your patient is hypoxic. Carbon monoxide diffusion capacity is again decreased because of the increase in the width of your pulmonary capillary vessels. How do you treat it? You give oxygen. What is the other treatment? Only other treatment is liver transplant. How much time will it take for him to get better after liver transplant? You do a liver transplant today, he is better in a week. 3 to 6 months. Some books have even mentioned 1 year. So you do a transplant, but you will have to shift the patient from your ICUs to ward on oxygen supplementation. We have shifted post-HPS patient on HFNC to wards also, where they have been on HFNC for a month, 2 months. Right. Now the CLT is over. Now we'll come to a few slides on acute and chronic liver disease. Now there are 3 major definitions of ACLF which have been given, and it depends on which part of the world you live in. So the Asia Pacific Association, the study of liver, says it is an acute hepatic insult manifesting as jaundice more than 5, and coagulopathy, that is INR of more than 1.5 or prothrombin activity less than 40%, complicated within 4 weeks by a clinical ascites or hepatic encephalopathy in a patient with previously diagnosed or undiagnosed chronic liver disease or cirrhosis, and associated with a high 28-day mortality. You can remember any one of the definitions you feel comfortable with. So there is no extra hepatic organ failure is required as per this definition. Next is the European Association of Study of Liver, Chronic Liver Failure Consortium. So ACLF is a specific syndrome in patients with cirrhosis that is characterized by acute decompensation, organ failure, and high short-term mortality. So there are 3 things. So the development of ascites, HE, GI bleed, and bacterial infection are defined as decompensation, and you may not even have history of decompensation. But organ failures include liver, kidney, brain, respiratory system, circulation, like shock, and coagulopathy, and they have to be assessed by the CLIF score. We'll come to the CLIF score. The North American Consortium states that ACLF is defined by the presence of at least 2 severe extrahepatic organ failures including shock, grade 3-4 HE, renal replacement or mechanical ventilation. So all the 3 definitions are entirely different. You can follow whatever you like. So this is the CLIF scoring system and given by the Europeans. So the organ failure, they have already mentioned in the definition: liver, kidney, brain, coagulopathy, circulation, respiration, and they are scored as 1, 2, 3. Also, the ACLF can be graded as from 0 to 1, 2 and 3. So 0 is there is no organ failure or a single organ failure in patients with serum creatinine of less than 1.5 and no hepatic encephalopathy, or a cerebral failure in patients with serum creatinine of less than 1.5. This is 0. ACLF 1 is a single kidney failure, or you have a single liver, coagulation, circulation or lung failure that is associated with creatinine levels are higher in this 1.5 to 1.9. This may or may not be associated with hepatic encephalopathy grade 1 or 2, or a single brain failure with serum creatinine level of 1.5 to 1.9. Grade 2 is 2 organ failures and grade 3 is 3 organ failures. What is important is, if you have a patient in ACLF 3, look at the mortality rates. So whatever you do, most likely he will not survive. So the management of ACLF is treat the underlying precipitating cause, give antibiotics for infection. If there is severe alcoholic hepatitis, give corticosteroids, and if there is an HBV flare, you treat with nucleoside analogs. You have to do a salvage liver transplant, but sometimes the patient is not fit for transplant immediately. You have to bridge them. So you can bridge using Mars or plasma exchange. Mars is now more or less gone out of fashion because of the studies showing no mortality benefits. So most of the time we are doing plasma exchange now. Right? Thank you.